Dr. Divya. Today I am going to present my paper on detection of vancomycin resistance in clinical isolates of Staphylococcus aureus in tertiary care hospital. Introduction. Staphylococcus species is one of the most common cause of nosocomial and community-acquired infections with high rates of morbidity. The advent and use of antibiotics such as penicillin and methicillin initially proved effective against Staphylococcus aureus but rapidly acquired resistance to these antibiotics. Vancomycin has proven effective in treating severe MRSA infections. Staphylococcus aureus clinical isolates with reduced susceptibility to vancomycin and less commonly with complete resistance have emerged within the past 20 years. Hiramatsu et al. Described the first Staphylococcus aureus with reduced susceptibility to vancomycin. VRSA strains acquired the vancomycin-resistant gene VAN-A operon encoded on the transposon TN1546 from the VRE, whereas the mechanism of resistance in VISA is due to the thicker cell wall mainly at the septum and increase in D-alanine containing mucopeptides of the peptidoglycan, which causes decreased binding of vancomycin to the lipid 2 site and decreased diffusion of vancomycin. Need for the study to detect and identify magnitude of VISA and VRSA in our hospital to make clinicians aware of this impending public health problem if inappropriate use of this glycopeptide is continued. Aim to detect vancomycin resistance in Staphylococcus aureus isolates. Objectives to screen for the vancomycin resistance in isolates using vancomycin screen agar to determine MIC by broth microdilution and epsilometer test. Staphylococcus aureus isolates from blood, excrete, urine clinical specimens are included in the study. Repeat Staphylococcus aureus isolates from the same patients are excluded. Sample size is 84 isolates of Staphylococcus aureus. This is a cross-sectional study conducted over a period of 4 months from June to September 2021. Material used are culture media like blood agar, McConkey agar, vancomycin screen agar, cation adjusted Muller-Hinton agar and broth, vancomycin hydrochloride powder with drug potency 950 microgram per ml, microtiter plates, microcentrifuge tubes and e-test strips. Method: samples inoculated and blood agar, McConkey agar incubated aerobically at 37 degrees centigrade for 18 to 24 hours. Staphylococcus aureus identified and confirmed by conventional methods which are subjected to AST, vancomycin screen agar, broad dilution. Epsilometer test performed on the strains which are VISA and VRSA. These are the pictures showing the vancomycin screen test, broad dilution and epsilometer test. Results: in the present study, total 84 Staphylococcus aureus isolates are included, out of which 83% are males and 27% are females. 70.3% of isolates are from pus and mostly from the surgical ward and orthopedic ward. Among 84 isolates, 52% are resistant to cefoxitin showing MRSA. Antibiogram showed 100% susceptibility to the imipenem, then the nitrofurantoin and linezolid, and doxy showed 90% susceptibility. On vancomycin screen agar, 7 isolates showed growth, that is 8% resistant, and 77 isolates did not grow, that is 92% sensitive on the vancomycin screen agar. The MICU on broth dilution and E-test are depicted in the bar diagram, which showed broad dilution showed 68% and E-test showed 70% with MIC less than 2 microgram per ml. Discussion: in present study, male to female ratio is 3:1, which is similar to Siddiq et al. And the sample distribution in our study is similar to the study carried out by Shittu and Lin. The prevalence of VRSA is 3.6 and VISA are 7.2, which is similar to Azadullah et al. The prevalence of VRSA isolates among different countries based on meta-analysis of published original article by Arif Sharia et al. Showed that VRSA prevalence is 3.6% in North America and South America, Europe 1.1%, Asia 1.2%, Africa and 2.5%. The difference between MICs obtained by the E-test and the broth microdilution reflect a 1 dilution higher vancomycin MIC when determined by the E-test, which is accordance with Mauna et al. The precision of the dilution susceptibility test method is plus or minus 1 2-fold dilution. Thus, a single dilution difference in the vancomycin MIC in the range of 0.5 to 2 microgram per ml would not have significant clinical implication. Conclusion: VISA are associated with persistent infections, vancomycin treatment failure, and poor clinical outcomes. This highlights the necessity to monitor and develop strategies to control the development of VRSA and VISA. Obtaining MIC is very important for therapeutic drug monitoring, which is useful particularly in patients in the ICU with unpredictable clearance. It is also important to routinely test the MIC for vancomycin for infection control to prevent resistance. Even though MIC obtained from E-test shows slight variation from the standard broad dilution, it have lower impact on the treatment of the patients. So use of the e-test can be recommended as alternative as it is rapid and easy test. These are my references. And World Antimicrobial Awareness Weekness is an annual week event conducted by WHO celebrated on November 18th to 24th to increase the